All right, so once again, good morning. And it is my distinct honor and pleasure to welcome you to the 9th Annual John W. Hatch Lecture and Symposium. On behalf of the Wake Forest University School of Divinity and the Faith Compass Center, we are so glad to have you here as we engage in critical questions around faith and health in our communities and society. I want to first begin by congratulating you for surviving the weather, for braving the flakes that decided they wanted to fly a little bit faster and heavier than what were forecast, but we are so glad to have you here. And as we begin this year's lecture and symposium, I want to start by recognizing the amazing people who have worked diligently to make today possible. The staff and consultants of the Faith Compass Center and the Wake Forest University School of Divinity. It is because of their efforts that we are here to undertake this important effort. And so I just want the Faith Compass Center and Wake Div staff and faculty to please just wave your hand to be acknowledged for helping to make this possible. Some of you have been longtime members of the Hatch community, and others are coming into the Hatch circle for the first time. Some of you are joining us here in person at Wake Forest University, and some of you are joining us virtually from distances near and far. Let me affirm that no matter your point of entry, you are welcome in this space. Today would not be possible without the support of an amazing group of sponsors, including Atrium Health Wake Forest Baptist, the Wake Forest University School of Medicine, the North Carolina General Baptist State Convention, the National Association of Community Health Centers, the UNC Gilling School of Global Public Health, and the Gilead Sciences Compass Initiative. We also want to acknowledge a powerful array of partners who have contributed to make today a success, and you will find their names listed in your booklet. Today, you will be part of a dynamic conversation around what health equity and justice look like, how technology, including artificial intelligence, impacts our journey to health justice, and how we activate theology, education, public health, medicine, and many other disciplines to propel that journey forward. We encourage you to be active participants in this dialogue. We have curated this day for all of us to raise awareness, engage in reflection, and plan for action around the topics of the day. Ultimately, we hope today either ignites or stokes your fire to advocate for health equity and health justice. And now I am honored to invite distinguished members of our community to the podium. We will now receive opening remarks from Ms. Debra Farrington, and then following Ms. Farrington, we will have the occasion from the Dean of the School of Divinity, Dr. Corey D.B. Walker. Dr. Ricky Banks was supposed to be here, but due to circumstances, he is not able to join us at this time, but we do want to acknowledge his presence and his support. And so at this time, it is my honor to welcome Ms. Debra Farrington to the podium.
It is my honor and privilege to bring you greetings this morning for this wonderful event. And I want to give special recognition to Dr. Hatch and to Dr. Holmes and all of the organizers of this event. And thank you for this opportunity to speak to you. I'm particularly grateful to participate because it gives me the opportunity to speak boldly and openly about two things that I'm passionate about: my faith and my work. And I appreciate your call to action, health justice in the 21st century, because it captures the very essence of our daily work at the Department of Health and Human Services. And for our team, our health equity team, some of whom are here today in person and others online, it captures our mission, which is to foster fair and just opportunities for all people in North Carolina to live their healthiest life and achieve their healthiest outcome. We're all quite familiar with health disparities that exist in this country and in North Carolina, particularly for people of color. People die much sooner than they should. They experience higher rates of diabetes and other chronic health conditions. And it's for this reason that the Department of Health and Human Services exists. It's our job to improve the health, safety, and well-being of all North Carolinians. And to do so, we know we must address the whole person, the body, the mind, social, and spiritual needs. And to add to that, I'm particularly happy to be in a community of faith leaders because the God I serve requires that we love justice and fairness. He gives justice to all who are treated unfairly. His throne is founded on two strong principles. The one is justice and the other is righteousness. I could talk all day long about justice and goodness. We know that mercy and truth are part of our responsibility as leaders in the faith. I believe that it's not only our mission, but it's a central tenet of many of our faith traditions, those of you who are here today to advocate for health justice. Once we do that, we will serve faithfully the people who are underserved. And to do so, we must be compelled by our faith traditions. We have to defend those who cannot defend themselves. Yes, we have to speak up for the poor and for the helpless and see that justice is given, health justice is given to all those who deserve it. If we do so, we know that justice will prevail, and this is the only way that we can live a successful life. Thank you very much.
Good morning. I'm honored to be here today with each of you for the 9th Annual Hatch Lecture and Symposium. This gathering, which honors and extends the pioneering efforts of John W. Hatch, is essential to the ongoing work of ensuring health equity for all people. For nearly a decade, the Hatch Lecture and Symposium has fostered thought-provoking dialogue at the intersection of faith and health, empowering leaders to improve health outcomes and build stronger communities. We at the Wake Forest University School of Divinity are privileged to partner with all of you as we strive for a just, equitable, and healthy world. A quarter of a century ago, Wake Forest University School of Divinity welcomed its first graduate students with a bold commitment to form agents of justice, reconciliation, and compassion. We have remained steadfast in that mission, deepening our dedication to its transformative power. We recognize that justice, reconciliation, and compassion are not merely ideals, but require healthy communities where all people can thrive. Our graduate theological ecosystem offers a comprehensive interdisciplinary approach to graduate theological education, engaging not only our own graduate programs, but also collaborating with graduate programs in business, law, medicine, and the arts and sciences. This ecosystem is further enriched by our critical partnerships with our congregational and community partners. At the heart of this commitment to the intersection of religion and health, and one of our most meaningful expressions of this work, is our Faith Compass Center. At the center, we partner with diverse African-American faith leaders and communities across the South to destigmatize HIV/AIDS and create spaces of healing, wholeness, and hospitality, essential work in rebuilding lives and communities. Our mission at the School of Divinity is closely aligned with the efforts to advance health equity, particularly through our collaboration with our Wake Forest University School of Medicine colleagues, the academic core of Atrium Health. This unique partnership allows us to reach communities across the Southeast, through the Midwest, and across the South, promoting justice, compassion, and reconciliation in the pursuit of health equity. We also are able to provide intellectual leadership at the intersection of faith and health. In this work, we take to heart the call issued by the Reverend Dr. Martin Luther King Jr. at the 1966 convention of the Medical Committee for Human Rights, where he boldly declared, "Of all the forms of inequality, injustice in healthcare is the most shocking and most inhumane." As we gather today, we are reminded of the shared commitment we all have to eradicate this most shocking and inhumane injustice. We're grateful for the opportunity to continue this important work together, and may God's grace and peace be with each of us in this gathering and in the days ahead. Thank you.
And so it is in that spirit that I would like to invite our first panel entitled Charting the Course, Health Equity Frameworks for Diverse Communities. Now, we've had a little bit of a shift in our panelists, and so this first panel will have 4 panelists instead of 3. And so I will call the panelists up first, and then I will invite our moderator to come up, who will provide opening remarks and then move into the discussion. And so at this time, it is my pleasure to invite to the stage Senator Paul A. Lowe, Jr., Ms. Yazmin Garcia Rico, Reverend Dr. Arlecia Simmons, and Mr. Jeffrey Sims. And we'll provide a chair for you in just a moment. And here to moderate this panel on health equity is none other than the Dean of the Wake Forest University School of Medicine, Dr. L. Ebony Boulware.
Morning, everybody. Good morning. What a wonderful occasion. It's really an honor for me to be here and moderate this section on health equity frameworks for diverse communities. As the Dean of the Wake Forest University School of Medicine and a lifelong scholar and advocate for health and health equity, I can think of nothing more important for us to talk about. And I'm so grateful for the opportunity to be a part of this distinguished program that's gone on for so many years. Today, we're going to talk about health equity frameworks for diverse communities, and I was asked just to open up this session to provide some reflections on health equity and get us grounded in common definitions. So, I think about health equity, and we'll get into that term equity, as the equivalent of health. We have no health without health equity. And I also think of health equity as a principle of justice. We have no justice without health equity. And what I think is really powerful is how our communities are affected by the health and the justice aspects of this health equity concept. And this is where our faith communities in particularly come into play, how people interact, how we work together to achieve something better and something just. Frameworks are very important as we think about community efforts to improve equity. And so I want to make sure we're all level set on the definition of health equity. This is a definition that comes from the Centers for Disease Control, and the World Health Organization has similar. That's the state in which everyone has a fair and just opportunity to attain their highest level of health. So everybody having the opportunity to achieve optimum health. And we want to distinguish the concepts of equality and equity by meaning that equality is we give everybody the same thing, and we don't necessarily care about where they're headed. We just gave you something equal. I give you one, I give you one, and I hope you guys end up in the same spot. But equity actually is about realizing that I give you one, and I might need to give you 2 to get to the same spot. So we need to be careful when we think about equality versus equity. Another concept is thinking about the differences between disparity or a difference and equity. So we often talk about health disparities, and I think subconsciously people may think about the equity concept, but a disparity is not the same thing as an equity problem. For example, if we look at prostate cancer and health, well, there's a big difference, disparity in the rates of prostate cancer for males versus females. That's a disparity. There's a numerical difference. But if we look at poor males versus wealthy males, we now see an equity issue, because we have all males, but then some males within that population don't have the resources or opportunities to be screened, to receive treatment, or to be followed up and have the best outcomes, and others do. And that results in health differences. That's an equity problem. That's a health equity problem. A third thing as we enter into our panels to think about the social determinants and drivers of health. We keep talking about that. We keep talking about that. And I always ground myself in thinking about social determinants of health being social factors that are influenced by power structures that disproportionately negatively influence some individuals in our communities versus other individuals in our communities. So every time we think about the social drivers of health, it's about the power structures that dictate social positioning in our society. So as we think about health equity, we're thinking about health and we're thinking about justice and how those two things interact to affect our power structures, our environments, and the things that affect our well-being as human beings. So today I'm really honored to moderate this panel, which includes experts from our community, from our governing structures, and from the faith community to talk about equity frameworks for diverse communities. So first, I want to talk to each of the panelists, and maybe you'll take a moment just to introduce yourselves and where you're coming from in terms of your perspectives on this. And I want to ask you, what does health equity mean in the context of your work? So if you could take a moment and just tell us the context of your work, and then tell us what health equity means. So would you like to start off? Thanks.
I'm Paul Lowe, North Carolina Senate, and also serve as pastor of the Shiloh Baptist Church, where I've been for a number of years. For me, when I look at health equity, for me it means access, and it means an opportunity for everyone to have access. And when I look at it, for everyone to have access, it means that we have to approach health care differently than our country is designed. We're a capitalist. That's what we are. And to make sure there's equity, we have to bring in socialism. I mean, and nobody wants to really talk about that. But we have to have socialized medicine if we want equity. You can't have equity without socialized medicine. That's why it took us 10 years in North Carolina for us to get Medicaid expansion accepted. Because what people were saying is true. It is socialism. And that's all right if we want people healthy. Now, if we don't want people healthy, then we can completely leave everything in a capitalist framework. And those that have means will get health care, and those that don't won't. And when I look at things, I look at it from that framework as a legislator. How can I get the numbers to get the votes to pass something that will help everybody? That's what I do. And some of the means that I go about doing that, some people would like and others might frown upon. I think we've worked together, and I remember succinctly if you'll indulge me a moment, an argument I had with, you probably remember, with Mandy Cohn. I said, you're doing all this testing, but you're not testing in the black community. Well, we have nowhere to test. I said, well, we can do a pilot program at Shiloh Baptist Church. You can do it right in the parking lot and start testing people. And we went from there to vaccinations. So it can be done, but it's going to take a lot of pressure and a lot of work if we actually want everyone to have access to health care.
Wonderful. Yeah, thank you. Excellent. Ms. Rico?
Good morning, everyone. Can you hear me? No.
Think should it turn it up? You want to flip it up? Is it flipped up?
Great. Good morning. Can you hear me?
Yeah.
Okay. Good morning, everyone. Yazmin Garcia Rico, Director of Community Engagement and Impact at the Cone Health Foundation in Greensboro, North Carolina. For me, health equity, as it was mentioned, means everyone having access to the health and to the resources and information they need to be healthy and to live successful lives. In the roles that I have held at the North Carolina Department of Health and Human Services and now at the foundation, the way that health equity comes across for me is making sure that we are doing everything we can in the strategies, in the programs, in the resources that we're putting forward to make sure that we're meeting communities where they are, making sure that we understand who we are trying to serve. And if we are focused on health equity, we're going to be looking at historically marginalized populations. And for me, this always comes across in the work that I do. I have been making sure that we are also lifting up the needs of the immigrant population. As an immigrant myself, as someone who identifies as Latina, making sure that we are not leaving people out when we are having those strategies. And so in the philanthropy sector, that might mean making sure that we understand who makes up the communities that are present and making sure that we are funding and supporting in different ways those organizations. But also, when I was working at the state, an example I wanted to share was around COVID response, where we were making sure that we were looking at the data, because data can really help us to drive our efforts, and data does not lie. So if you were looking at the numbers, we saw that there were disproportionately, the communities of color were disproportionately impacted by COVID, and that way we were able to drive our efforts to make sure that people were getting tested and vaccinated. In the role that I had at the time, my focus was again, the immigrant Latino population. And so we were making sure that our communications were provided in Spanish, that we were developing the relationships with community-based organizations, with community leaders, that we understood what the concerns that people had were being addressed in simple language, in Spanish, and in many ways, meeting the community where they were. So given that we were doing, for example, work with Spanish media, the radio, TV, Facebook, and so on. And so I wanted to provide that example because, as it was mentioned earlier, equity is much different than equality. You're not gonna be doing the same thing for everybody because that's not gonna reach all populations. So you really have to understand who is falling behind and how you're gonna make sure that you're meeting them where they are and support them to be able to have healthier outcomes. And the result of all the efforts at the department during the COVID response were that the Hispanic population ended up being vaccinated at a higher rate than the non-Hispanic population for at least one dose. And if you remember, there were many doses that came after that, and hopefully you have gotten your COVID shot already this year, but it is a continuous effort, and you continuously have to make sure that you have a touch with the community to make sure that you're hearing and responding to their needs. So that's a long answer about health equity, but it is really important that you have that connection, and for me, that representation at the table when the discussions are taking place to make sure that we are thinking about everybody that is part of our community.
Wonderful. Thank you.
Thank you. My name is Dr. Arlecia Simmons. I'm with the North Carolina Council of Churches, and we are a nearly 90-year-old organization based in Raleigh. I'm the East Regional Associate Director, so I am based in Fayetteville, technically covering half of the state. And so in addition to what both of the speakers have said, when I think of equity, I think of our ecumenical organization. And so we come from a Judeo-Christian framework. And so as we think about the work that we do, we think about some of those healing stories in the Bible as a Christian minister. And when we think about the healing stories, some of you may be familiar with the lepers in the Bible. And those people were disconnected from society. And so when we think about equity, we think about bringing people back into community. When you are sick or don't have the ability to get health care or don't know how to ask for what it is that you need, then you are marginalized and you are on the margins and unable to be in the fullness and the wholeness that the biblical script promises. And so that is the work that we do, walking alongside congregations. We are in the trenches in many rural communities where we know that there are disparities and inequities. And so the thing that we have the ability to do because of the position we're in, we are able to activate people who are in the pews, whether it is the synagogue, whether it is in the church, the Baptist church, the storefront church, and remind people that equity means that not only are you a person of faith, but you're also a voter. You're also a taxpayer. And as a voter and a taxpayer, you do have the right to cry out. And cry out not only asking God to heal you, but cry out to your legislators and cry out to the people who come to your congregations and ask for your vote. And cry out and tell them what it is that you need, if not for yourself, for the people who are in community with you.
Excellent. Thank you.
Good morning. I'm Jeffrey Sims, an assistant professor at the Gilling School of Global Public Health. And I just want to celebrate Dr. Hatch, first of all, and his amazing legacy. I've had the privilege of being at all of these lectures over the last 8 years, I guess, and it's been such a pleasure. I also serve as a pastor of 2 rural congregations in eastern North Carolina and serve as associate chair for the Department of Health Policy and Management at the Gilling School of Global Public Health. And we're really excited about being able to sponsor. And so when I think of equity, I think of community as well, and really think of ways that we can ensure that community has access and that is fair and just to equal or health care. So one of the ways that I approach it is I really feel like I'm helping to train students to bring an equity lens to everything that they're doing. Understanding that when you are being trained in the public health space, it is around population health. And so really getting students to understand the importance of never losing sight of the patient and the individuals who are being served by that. I have students who will go and they'll be health services researchers, but I'm saying to them, it's not just numbers. You've got to look at the data is so important, but you've got to recognize that those numbers represent individuals and people and community. And so you've got to be intentional around that. And then I shift to my pastor's hat and then say to my congregation that we are in community together. And how do we function in community together? By improving access to healthcare, by being very strategic around ways to ensure that our neighbors have access to healthcare. Those who are sitting beside us on the pew have access to healthcare, and ways that we can then empower our congregations to do that. So those are the strategies and the approaches that I take in the spaces that I function in.
Wonderful, thank you. Really grounding us panelists. Can you talk to us a little bit about how social drivers contribute to the inequities that you see in your varying different areas? And how does health inequity begin to look like across the lifespan of individuals within communities? Anybody want to take that one? Senator Lowe, you want to start with that? I'll put you on the spot.
I don't know that I can say much more than I've already said. From where I sit, everything is based on taxpayer dollars. We have a budget. The biggest part of our budget is education, health, and human services. Then you get down to the other state needs. In a discussion I had during in the legislature on yesterday, I said, because I'm partisan, I said Democrats have to come to grips with the fact that you can't give all the money away. And Republicans have to come to grips with the fact that you can't defund the government. You've got to find some middle ground to get things done and to provide the opportunity for individuals to have access. One of the most interesting things that I remember coming across during the pandemic was the fact that you can provide access, but the very access you fought with people to get, a lot of people don't want it. And sometimes it's the very people that need it the most that just don't want it. And for me, I depend upon folks like you all that are on this panel to do that part. I'm gonna try to get the money. I'm gonna try to get the resources. But you all have to figure out how to make it work and how to not make me look stupid because I did everything I could to get the resources for it, and then sometime the very people that need it the most won't engage it. And that's becoming a real stickler with me at a lot of different levels, that we gotta figure out a way to help people engage health care if the means are there to get it, to access it. And I don't claim to know what those answers are, but I think it's important. I know it's important.
And just to follow up, I think one of the ways in which our work is so pivotal is to your point, we help serve as the translators. And for example, with Medicaid expansion, for the 10-year journey, walking alongside, making sure that people in our churches understood how, what it is you were doing in Raleigh, but translating it for them to understand what it looks like on the ground. Why is this so important for our communities? And so when we talk about the social determinants of health, one of the things that we are focused on in our work is we, of course, deal with ACEs, and we talk through often racism and the impact of racism as it relates to mental health. That's one of the areas where we work with congregations across the state. We have, with the assistance of the Duke Endowment, been able to put funding in churches across the state so that they can begin their own mental health programming. And so one organization writes that racism is a mental health issue because mental health creates trauma. And so that is what we are dealing with in many of our congregations. And sometimes that trauma is internalized because it can be our own toxic theology that then we walk alongside congregations to help them re-narrate the way in which we talk about mental health and the way in which we talk about opioid or harm reduction. And so that is how we are working with congregations so that, and this is just a personal thing, when I go in congregations and I talk about, let's talk about your sick and shut-in list. Who's on those lists and how many generations of the same family are on that list for the same comorbidities? And so when you think through a question like that, how do we get it from a sick and shut-in list to a healing and recovery list? And so that is how we walk through and walk alongside with congregations, giving them the tools, the training, the language, and sometimes confronting ourselves as clergy and clergy leaders about how it is that we are articulating our voices in different aspects, because there is this nervousness or anxiety about the separation of church and state, and we don't want to lose our 501(c)(3) so we can't say nothing against the government, but also reminding people you have a prophetic voice. And you are called to speak and called to motivate and activate people and at least give them the basic information. You can't tell them how to vote, but you can tell them what to vote and how to think about what they're voting about and give them the information.
I think information is so critical. And so I think it allows us to then inform communities. So you were saying, Senator, that many of the communities are not taking advantage of the programs or resources that are available to them. I think we have to be intentional, and this is where gatherings like this enable us to empower the communities with information to then affect that. And so perfect example is Medicaid expansion. I mean, I think if I'm not mistaken, we've done a pretty good job with the Medicaid expansion and getting folks enrolled based upon the recent expansion that happened. And when you also think about the ACA, or what we call Obamacare as well, there were a lot of resources put into local communities to create and identify navigators who can help folks get access to those services. So I think what we've got to do is to change our model of thinking and hiding things and really making it more available and really identifying the community voices that can help to make that happen. And so I think we've got to continue to empower those not-for-profits who are there and who can really, who are boots on the ground and can enable those communities to then access those resources, but also access to people who need the resources. When I think about some of the congregations that I serve, I don't go in there talking to them about just health equity. We deal with the same thing you were talking about. It's like, let's look at what has been some of the historical and cyclical sort of illnesses that we've seen in our community, and how do we then break that cycle? It's also the same thing with some of the programs and various things, and this is where I think the social drivers come in. So prior to me joining faculty at UNC, I was the assistant director of the Medicaid program, and we were then focusing in on how do we enable Medicaid patients to have medical homes. Because if we can have individuals with medical homes, we know that we can improve the outcomes, especially for children. And so we started dealing with low-hanging fruit. Children who suffer from asthma. If you figure out strategies and ways to really kind of support those children who suffer with asthma. And so what did we have to start doing? We had to start going into the homes, social drivers, and then seeing that the environment that many of the kids were living in is what was then causing them to have the asthma flare-ups that resulted in them being in the emergency room. So once we then said, well, let's start being creative and start using some of the funds to pay for things like portable air conditioning units that can go into helping to remove the rugs and those various things that are in the carpets that are in the homes that are really causing the problems. Those are the ways that you really take it to the boots on the ground effect, and you can then begin seeing some of the outcomes and the improvements related to that.
Thank you, and I'll try to be brief. So when I think about the social drivers, for the Cone Health Foundation, we were one of the first foundations in the state that started to really promote Medicaid expansion since the beginning. And so this was really important for us, being a health legacy foundation, that we wanted to make sure that everybody who was eligible for Medicaid would benefit once expansion happened. And so this work took many years, and for that long we were supporting community-based organizations in Greensboro specifically to support them to make sure that the community had access to care, especially for uninsured populations. And now with the expansion of Medicaid that happened about a year ago, we know that across the state more than 577,000 people have gained access to Medicaid, which is a great win. Not everybody is eligible. Unfortunately, we still have a population that, a part of the population that is not qualified for it. But that has given us an opportunity at the foundation to expand the social determinants of health. And so we're working on that shift right now where we're not only going to focus on access to care, but we also will be tapping into access to healthy housing, healthy and affordable housing, economic mobility, education, and also still access to care and access to healthy food. So we're transitioning because of this win of Medicaid expansion. And when I think about social determinants of health, again, always elevating what additional barriers people face for the immigrant population is language barriers, maybe literacy or education levels, and concerns around immigration status as well. And so social determinants of health, oftentimes we think about those basic ones like education, housing, access to healthy food, but there are other layers as well that many people in the community are also facing, and we have to make sure that we also address those. And so just wanted to elevate that. I think expansion has taken a coalition effort like across the state from different angles. And also from the side of the department, when I was at DHHS, I know that a lot of the lessons learned from COVID, we were able to bring them in very quickly for expansion, to be able to continue to work with the community serving organizations that are on the ground and that have the trust. And so I wanted to elevate that because earlier was the point of sometimes you want to serve the community and the community is not ready, right? We want them to jump in and this is for you, get access to this resource. But we have to understand that historically there has not been trust many times in institutions, in governments, government agencies. And so we also have to keep that in mind and take that in consideration as we are developing strategies. How are we gonna make sure that people are receptive to what we are trying to do, what we're offering, this resource, this information, to make sure that they listen, and maybe we are not the only ones sharing the message. It's a coalition effort and people that they trust, the churches, the organizations on the ground.
Excellent. And that comment leads me into the next question I have for all the panelists for you to think about. As we're talking about health equity, we need to think about the path that's led us to where we are and our current moment in time. And so when you think about the factors, social, historical, cultural, and otherwise, that led us to where we are, and in our current time period, how are we going to avoid losing ground? What do we need to do? So each of you, please start to talk about that. Thank you.
You shouldn't have asked me that. People, voters, in many cases, vote against their own interests. The only reason you have Medicaid expansion in North Carolina is because rural hospitals were closing. Let's be clear. This is a capitalist country. And everything is based on money. Most of the people in here have retirement programs, right? If your retirement program isn't invested in Lilly Pharmaceuticals, it should be. Because they make insulin products. Everything is based on money, whether we like it or not. The only leverage we really have if we want to see a continuation of what we have with Medicaid expansion and to make it even better, we got to vote. Because there are people in my chamber that want to dismantle it because of money. And I think that we can't skip over that. We got to encourage people to vote and vote for those things that are going to actually help them. Because I guarantee you, the people that want to make more money, they're going to do whatever it takes to dismantle. They don't care who it hurts. They don't care about any of that. And I think those are some real things that we have to begin to look at, to enjoy all of the benefits and to even expand upon the benefits that are already there. Yeah. You have to have legislation, which is a long, slow process at first. When they finally make up their mind, it moves really fast. But those are the things that we've got to do. So, and if we don't do that, we're going to be in pretty bad shape, or maybe even worse, because there is a climate right now that is most concerned about the bottom line and about people that are rich and wealthy. So those are some real things to think about.
Rico, you want to take it? Yeah, the social, historical, cultural, otherwise things that led us here, and how do you think we're going to avoid a backslide?
So what has led us here? I feel like for me, the last few days, weeks have been really heavy. As an immigrant, I was undocumented for more than 10 years. Benefited from a work permit provided by former President Obama, eventually was able to adjust my status to become a resident and eventually a citizen until I was finally able to vote in 2020. And so my journey has been long, and at the same time, it's not the same for many people. It's not the same opportunity that other people need also, and that are deserving of this opportunity. And so historically, if we look back, immigrants as a population have always been seen and used when needed for the economy, for jobs. They're seen as cheap labor. They're seen as a workforce that works hard in the fields, in construction, in restaurants, in many areas. And so when we need the workforce, we're welcoming, they come through the H-2A visa if they're farm workers. And when things get tough, when the economy gets tough, we want to detain them and deport them. And it happens to be now that immigrant population is Latino, but it has happened to other populations as well in the past, throughout history. And so what has led us there for me is racism and also economic gains for a few. And how we move forward, I'm still grappling with that. Because policy is important, making sure that people get out the vote is important, but there's only a few elections, right? Like it's like we have to wait until next year. Like every year there's an election, but also like some elections that are very important don't happen as often as we need them to be. And so for me, what happens now is what do we do now on the ground? What do we do in communities to make sure that we are supporting each other, checking in with our neighbors, understanding the political context and how it's impacting from federal, state, local to everybody in the community. I'm thinking a lot about students who are in school right now, who are hearing a lot of things. Just recently, HB 10 was passed, and there's a lot of impacts on education, but the other aspect too is that HB 10 is asking law enforcement agencies throughout the state to work with immigration. And, the language is for like criminals and people who have, committed crimes. But we know, as it has been done in the past at the local level, that oftentimes this type of policy is used to racially profile people. And so to me is, what do we do now? How do we help our friends, our neighbors? How do we check the children? How do we prepare if there is separation of families? How do we prepare if many immigrants, even those that have a status, because there's a lot of mixed status households, they're gonna be dropping from WIC, from SNAP, from Medicaid because they're afraid and they don't wanna deal with the government, right? Like they wanna like not be able to expose themselves in any way possible. And so how we move forward, I think that's a question that I pose to all of you. What can you do within the spaces that you are to make sure that you don't forget about this population? If we're really thinking about equity, we gotta meet people where they are, and we gotta remember, how we can be a very diverse and rich community, and we benefit from that richness. And it's not fair to kind of push and pull whenever we want people to be part of it and whenever we want to exclude them.
Amen. That's good. That's good. Just to respond to what you just said, we are thinking through and processing and praying about how do we help churches respond and how do they become places of refuge. Because congregations got buildings, And we have seen in the past where people have lived in churches because that was the place of safety for them with ICE and other agencies. And to respond to the senator and what he said, how do we move forward? We continue to pray with our feet and with our vote. And we all know that there is this attack on silencing nonprofits, especially nonprofits like ours and yours, who serve the least of these and who speak for those who don't feel like they have the voice to speak for themselves. And so I think how to move forward, I think I'll have to come from a pastoral note. This is our first week of Advent, and we are grounded in the tenet of hope. And so as we gather in this space, even if you are not of the Christian community, that is what we look forward to, hope. And Paul says hope doesn't disappoint. And even though we know what the outcome of elections are and what the ramifications of that might be, we have to, do as my ancestors say, I'm not going to let nobody turn me around. So then what does that look like? And so after our most recent election, I said then my work is more important now than it has ever been. Because if I am helping congregations think through how to offer mental health services, the people in the pews, yes, we can pray and we can read scripture and we can meditate and do all of our spiritual disciplines, but we're really going to have to know how to ground ourselves and how to help others who may be angry or who may find themselves in a moment of violence because they are trying to protect themselves or their neighbors from some injustice. And so I just see it as thinking about how do we reimagine the work that we do, whether you are a preacher, whether you work with an agency, how can I serve my community? How do I re-envision what it is that I do, even with changes on the way, whatever those changes might be? How do I work so that the people who have who've been before me and those who come behind me will find me faithful? Because I've continued to keep to use a churchy term, I've kept my hand on the plow during this season, and I have not allowed the what's to come, because we're always thinking what's to come, and it's all bad. But when we think about hope, hope doesn't disappoint. And so we have to envision what we hope to maintain, what we hope to keep, and then what we hope to do to make sure that the people in the state get what it is that they need so that they can be whole and happy and healthy, and we can all be in a place of healing.
Let's be real, the election depression is real. It was a tough place to be in, and it still is a tough place for a number of folks. And so, because you also acknowledge, you understand the harm that will be done in these 4 years, but also beyond these 4 years. And so as I was struggling with my election depression and really working through that Wednesday was a tough day. But after about a 24-hour period, of doing all the spiritual discipline that I needed to do, and the things that were not spiritual disciplines that I also had to do, that required me to process and to deal with all of that, I heard my ancestors speak to me. The son of a sharecropper from eastern North Carolina. I grew up between two tobacco rows in eastern North Carolina. My father had an 8th grade education. But one of the things that he instilled in my siblings and I were that you will not be doing this. He broke the cycle. Because sharecropping really was cyclical. My grandfather was a sharecropper. My father was a sharecropper. And when the owner of the farm came to my dad and said, well, your oldest son is now 12, 13, keep him home from school so he can help you with this farm. My dad said, no, I work 24/7. I will not allow that to happen. And so I heard my ancestors speaking to me. I heard my daddy saying, boy, yeah, it's been rough. It's horrible that election went the way it did, but you've got to rise up. You got to be reminded of the hope. And then that same hope, you got to instill it in the congregations that you are serving and the students that I work with every day. because they've got to realize the impact that they can have on other lives. And so I want to go to something that you said earlier, and it's important to understand who are the trusted voices in our communities that we then can allow to help us progress and move forward and move through this. We've got to identify those trusted voices. We've got to continue to empower those trusted voices so that individuals and communities can hear that, yes, there's got to be information, and you need to have accurate information. I mean, I think we're wrestling with a time where there is so much misinformation that just gets spread so quickly. So we got to figure out, how do we continue to relay accurate information and empower individuals to take advantage of what resources and programs and things that are available to them. But it's going to be hard. There are going to be obstacles that are going to come. But we got to figure out, how do we then navigate around the obstacles, and how do we allow ourselves to really kind of continue to be those trusted voices. And it's settings like this that we can empower communities to do that.
Wow, powerful, 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 powerful. Thanks for those incredible insights. I have one more question for you as a panel. So for faith leaders who want to better understand health equity issues in their communities, their own communities, but don't really know where to start, does anybody have some recommendations about some entry points for these leaders? Professor.
Can I go first?
Oh, okay.
I have a couple, and the first one is to really understand what is happening at the county level regarding health. Looking at the community health assessment, which is a document that gets posted about every 3 years. And so that will give you a really good idea about what areas in your community have more inequities. And oftentimes there's a 10, 15, 11 life expectancy difference from one side of town to the other. And so that can really help you narrow down your efforts in what part of the community you want to work closely with. And develop those relationships, those partnerships with churches, with community-based organizations. But oftentimes that's the place where I really encourage people to take a look at. When the community health assessment is comprehensive, they include different populations, different ages, different programs. And after the assessment, there's a health improvement plan. So you can also take a look and see what at the county level is being proposed to address those needs, and how maybe you can partner and be part of those solutions, and also held, local elected officials and people in organizations accountable for the work to make sure that they are really meeting the community's needs.
And I'll add to that, one of the new initiatives we have is we are helping communities who are going to partner with us on a new project we have called the Abundant Life Project, which actually focuses on mental health, helping them walk through the community health assessment and then understand how to access those resources. And one of the things I'll remind people, our health departments, our county health departments are so instrumental. And I think people see it like, oh, I'll go for a shot, or, I'll send a teenager there if they got, a little situation going on. But the county health departments, they have professionals who are waiting to talk to us. They have programs, they get grants from different agencies, and they want to come to your churches and your congregational spaces and do programming. And they are flexible, even though their schedule is usually Monday through Friday. The people in the health departments I've been able to work with, they are flexible. They want to see you face to face. They just don't have the time.
That's right. That's right.
Yeah. They do nights and weekends, and people don't realize, it goes back, you are a taxpayer, okay? You're a voter, and they want to work with you, and so that's kind of the starting point. You want to talk with your congregation about diabetes. You may not be able to get your doctor to come, but you can call the health department. They have a diabetic education program that they will help you implement so that after they've left, then you'll have more information.
Let me say something about that, just to put in a plug for our health department here in Forsyth County. We were able to do some amazing things, and some of those folks are in this room right now, that helped to bring to Shiloh Baptist Church, which is in the middle of East Winston, all kinds of stuff going on. But the health department worked night and day, early mornings at the church, helping people to get vaccinations and all kinds of things. And a lot of those people came to the church. They wouldn't walk down the street 2 blocks, literally, but they would come to the church to get those services. So I think as pastors, and I'm speaking particularly to you all that I know and see, as pastors, when it comes to having those kinds of things in our churches, particularly to you, I see my president there, particularly to you that are Baptists, if there is any bureaucracy in the church, you are it. So you can just make these things happen. You can invite these people into your churches. And one of the reasons I wanted to say something about this, when you invite them in, then I don't look stupid in Raleigh because I've acted a fool to try to get this money. Yeah. I mean, do y'all follow what I'm saying? Yes. Or maybe voted for something that I didn't like at all so that we could get some of these things, because it is a trade-off. So I encourage you to use the health department. There's some great folks over there, and they want to serve and they want to help. That's all I want to say.
Yeah, that's perfect. And I would. Sorry. Is this on? Can you hear me?
Yeah.
Okay. So yes, you have given great resources, and I would just remind us the role that Black church has always played in community. And so it's important for us to take advantage of that. The other organizations I would acknowledge and say that we should be using as resources: federally qualified community health centers, local rural health centers. And so really being it, because remember, a significant portion of North Carolina is rural. Most of North Carolina is rural. And so it's important that we then understand that perspective. Also empowering our members in our congregations to become members of the local board of health, to become members of the local board of trustees of the local hospital. Really kind of playing roles and being able to be active in those places. And then the final resource that I would say is looking at what does the local philanthropy look like in your community. There are local foundations that will support many of the initiatives that we've talked about today, or ways that you can then support that. And it's not only Duke Endowment and KB Reynolds. There are other local legacy foundations that were formed when hospitals were purchased and merged. And so the local, the profits for that went into these local foundations. And so really taking advantage of those is something that I think is very important as well. The other one is the Council on Aging. Whether we want to acknowledge it or not, and Jim Johnson taught us that last year, the silver tsunami is here. And so we've got to figure out ways that we can then begin to support our aging population and our aging community. And the only way we're going to do that is to start really addressing some of the workforce issues that we've got going on in our communities.
And I think a final one is NAMI. And so NAMI is a statewide organization, as well as they have different branches across the state. There's an interactive map that you can go on their website for North Carolina, and it will let you know. And so most times, those are people who are in community with you, promoting mental health education, and that is so important as well.
Wonderful. Well,
And 988. So 988 is the hotline. And so if you know anyone who's having crisis, it's not just suicidal ideations, but if you just need somebody to talk to, call 988. In our state, it's based, I believe, in Greenville, the actual line. And so I think they're working out the system, because based on your area code, it might patch you to where the area code is. But I think the system is trying to work out. So if you're physically in North Carolina, it'll ring to the Greenville number.
well, I want to thank this distinguished panel for an outstanding panel and discussion.